Hello everyone, welcome back to my channel. So now we will discuss about a new topic, that is anti-rheumatoid drugs. So drugs which can suppress the rheumatoid process and bring about a remission and retard the disease progression. These are the drugs which are known as anti-rheumatoid drugs. These don't have a specific anti-inflammatory or analgesic action. So they need to be combined with NSAIDs, and this combination is known as DMARDs. What is DMARDs? These are disease modifying anti-rheumatic drugs which are also known as slow acting anti-rheumatic drugs. Okay, so now what we should discuss, which disease we are talking about. So rheumatoid arthritis, it is an autoimmune disease and in which there is a joint inflammation, synovial proliferation and destruction of articular cartilages. Okay, so in this there are immune complexes that has IgM activation complement, and they releases cytokines, mainly TNF alpha and interleukin 1, which are chemotactic for neutrophil, and this inflammatory cell they secrete lysosomal enzyme. Okay, and these lysosomal enzyme they damage the cartilage and erodes bone, and the prostaglandin which are also being produced during this inflammation they cause vasodilatation and pain. Okay, so multiple small joints of hand and feet they are preferably affected, and deformities are also produced as the disease progresses. NSAIDs, these are the first line drug which can afford a symptomatic relief in pain, swelling, morning stiffness, immobility, but they are does not arrest the process of the disease. So what is the goal of drug therapy in rheumatoid arthritis? That we have to decrease the pain, swelling and joint stiffness, and we have to prevent the articular cartilage damage and bone erosions, and prevention of joint function and prevent deformity. Okay, so mild or early cases they can still mostly treated with NSAID alone. The current recommendation is to add a DMARDs as soon as the diagnosis of rheumatoid arthritis has been confirmed. However, use of DMARDs is early mild rheumatoid arthritis should be weighed against the potential adverse effect, which may be serious. So more than one DMARD may be used concurrently. Advanced cases may require 2 or 3 drugs together because all DMARDs tend to lose effectiveness with time. So we have to change the DMARDs. Okay. So the drugs for rheumatoid arthritis, which are anti-rheumatic drugs, they have been classified into two types. These are DMARDs, and these DMARDs are being classified into two types. One is the biological agents, and second are non-biological drugs. So non-biological has another two type. One is immunosuppressants, another is immunomodulators. In immunosuppressant we have methotrexate, azathioprine and cyclosporine. Okay, so in this video we will discuss about non-biological drugs. Okay, let us discuss about immunosuppressants. So first, the drug that is methotrexate, it is a drug of choice in rheumatoid arthritis. It is a dihydrofolate reductase inhibitor, and it has a prominent immunosuppressant and anti-inflammatory activity. The beneficial effect in rheumatoid arthritis, that is because of inhibition of cytokinin production, that is TNF and etc., and chemotaxis and cell mediated immune response. The induction of oral dose, when we give it like 7.5 to 15 mg weekly methotrexate regimen, it has improved accessibility to this drug in rheumatoid arthritis. Okay, so onset of symptom relief, it relatively is very rapid, that is 3 to 6 weeks, and methotrexate is a drug of choice and a standard treatment for most of the patients of rheumatoid arthritis. Response is more predictable and long-term response is there. Oral bioavailability of methotrexate is variable, and it may be affected with food, and its excretion is hindered in renal diseases. Therefore, it is not much recommended for such patients that have a renal failure or toxicity. And there are other drugs like trimethoprim that can add to inhibition of dihydrofolate reductase and depresses the bone marrow. What are the side effects of this? Side effect of low dose of methotrexate are oral ulceration and GI upset. And prolonged therapy, there will be a dose dependent progressive liver damage. so leading to cirrhosis, which is occurring in some patient. So we should never give methotrexate in patients having any hepatic abnormality, because there is excretion problem as well as there is toxicity problem. So contraindicated in pregnancy, breastfeeding, liver disease, active infection, and peptic ulcer. Okay, now we will discuss about another immunosuppressant, that is azathioprine, and this purine synthetase inhibitor, azo, it is being converted into 6 mercaptopurine by an enzyme, that is TPMT. That is, this TPMT means is thiopurine methyl transferase, and it is a potent suppressor of cell mediated immunity, appear to selectively affect the differentiation and function of T cell and natural killer cell. It also suppresses inflammation. However, remission is used in smaller percentage of rheumatoid arthritis patient and less commonly used. So, and also it is not combined with methotrexate. We should remember that. Okay. Now we will discuss about other immunomodulators under the category non-biological drugs. So there is a sulfur salazine. This is a combination of sulfapyridine and 5-amino salicylic acid, that is known as 5-ASA, and it exerts anti-inflammatory activity in bowel and is used in ulcerative colitis, and it also have a property to suppress the rheumatoid arthritis. Okay, the mechanism of action is not known. The sulfapyridine is split off in colon by the bacterial action and absorbed systematically, appear to be active moiety. And in ulcerative colitis, the main action is because of 5-ASA. Okay, efficacy of sulfasalazine in rheumatoid arthritis, it is modest, and side effect may be unpleasant. Neutropenia, thrombocytopenia, it can occur in about like 5 to 10 patients. Okay, regular blood count monitoring is needed when when a patient is on sulfasalazine drug. Hepatitis is possible, and sulfasalazine is used as a second line drug for milder cases of rheumatoid arthritis, and it can also be combined with methotrexate. Okay, so now we will discuss about the last drug in this category, that is hydroxy chloroquine. These are anti-malarial drug, and they are found to induce remission up to like 50% patients of rheumatoid arthritis, but it takes a longer time, that is 3 to 6 months. It has a low toxicity, that is a good thing, but it also have a efficacy that is also low. They are found to reduce the monocyte interleukin 1, and consequently it inhibits the beta lymphocyte as well. Okay, for rheumatoid arthritis, these drug has to be given for a longer time, and when we are giving this drug for a long time, they will accumulate in tissues which are especially melanin containing tissue, and they produces toxicity, and most disturbing of which have an effect on kidney, that is it causes renal damage, and it also causes corneal opacity. Now we will discuss about the side effect of this drug. So the side effects such as rashes, graying of hair, irritability, bowel movement, and myopathy, neuropathy, these are some adverse effect. They sometimes combine with methotrexate, and they can also be combined with sulfasalazine. And there is another drug we should discuss, that is Liplomid. This immunomodulator, it inhibits the proliferation of stimulated lymphocyte in patient with the active rheumatoid arthritis. And clinical trials, when the clinical trials were done for this, its efficacy has been rated comparable to that of methotrexate, and onset of benefit is also faster, because in methotrexate it was 3 to 6 when there was a onset of relief of symptoms. In this there is 4 week. Okay. So Liplomid, it converts into an active metabolite. Okay, it has been converted into an active metabolite in the body, which it inhibit dihydroorotate dehydrogenase and pyrimidine synthesis in our actively dividing cells in the body, and antibody production of beta cell may also be depressed. The active metabolite, it also has a very long half-life, that is 2 to 3 weeks. That is why it is given in loading dose, initially 100 milligram and daily for 3 to days, and followed by 20 milligram once in a day. So there is an important point, that is Liplomid is an alternative to methotrexate or can be added to it, but the combination is very hepatotoxic, so we should not give to it. Combination with sulfur salazine, it improves the benefit of this drug. Okay, so that's all for this video. Thank you for watching and please subscribe to my channel. Thank you.